Thank you for the nice introduction, Laura. Thank you for inviting me today to moderate this session. I'm obviously delighted to be here. Joining me in this round are 4 leading experts who'll be giving a short update on their experiences of running an HIV clinic during the COVID pandemic. We have in this session Nadia Naous from the UK, Leonie Meemken from Austria, Riccardo Rondina from Italy, and Catarina Esteves Santos from Portugal. And what we plan to do is give each speaker 5 minutes to take the floor, followed by a couple of questions, and then we'll move on to a Q&A at the end with everybody. As Laura's highlighted, do feel free to put any questions you might have in the chat, and I will try and raise them with our speakers. So first we'll hear from Nadia Naous, who is the lead director pharmacist in the HIV and GUM clinic at Chelsea and Westminster Hospital in London. Nadia, can you give us an update on what's been happening at your service in the past few months?
Sure. So I'm going to start with speaking about the UK pharmacy experience with a particular focus on the London experience. So across London at the start of the pandemic, the majority of our services closed face-to-face services to varying degrees. Our centre, which consists of 3 central London clinics, 1 outer London clinic and 3 clinics in surrounding counties, decided that we'd close 2 of the inner London clinics in order to concentrate clinical staff who hadn't been redeployed to inpatient services in order to ensure efficient running of remote services and also support the smaller numbers of people who did need to attend face-to-face services to do so in a safe and timely manner. During this time, we only had people attending for urgent bloods, and all routine blood tests were suspended for stable patients. And at that time, this was for potentially up to 6 months, as we deemed the benefit of reducing footfall to the clinics greater than the risk of missing routine monitoring. So people didn't attend if there was no concern about HIV-related complications, viral rebound, or drug toxicity. We very quickly set up ad hoc phone clinics and integrated triage into these to make sure we were identifying people who needed to attend urgently or come to the hospital for rapid review. In the early stages of the pandemic, when the redeployment plans for nursing, medical and pharmacy staff hadn't been finalised, we used the time that we had to work through the booked clinic appointments, in some cases up to 6 months in advance, by contacting patients to cancel their appointments, provide reassurance as many were anxious about being potentially at higher risk, and make sure that we arrange medication supply. In those weeks, we were inundated with prescription requests, and not all of these were urgent, and many were driven by anxiety that access to medication might be compromised by the pandemic. However, it was very difficult to prioritise these due to the volume. We used automated replies and our websites to communicate that medication supply wouldn't be compromised, and if people had less than a 6-week supply remaining, please could they hold off on contacting us to request their prescriptions. This rush for antiretroviral supply wasn't unique to London, and it was also driven partly by the fact that a number of people were leaving London at very short notice, some due to the perceived high risk of living in a densely populated area, and others for more personal circumstances, such as being furloughed, their place of work closing, and sometimes not being able to afford their accommodation. And some of these people had no clear follow-up plan either. So another big challenge for us, whilst trying to reduce footfall, as Laura's already mentioned, is trying to identify solutions to get medication to people, particularly those who were self-isolating. Early on in the pandemic, our home delivery companies that we used to transport medication to people informed us they didn't have any capacity for new patients, which left the majority of us either using courier companies or the postal service. In our centre, we were very lucky to be able to use our trust transport service and existing employees to get medication to people. There was a point at which postal deliveries were delayed for about a month, so in some cases, courier companies did have to be used. At a very early stage in the pandemic, our regional leads, including Laura, set up regular online meetings between all of the London HIV pharmacy services so that we could help to ensure continuity of service and also share important information in real time. Through this, we learned that one of our nearby HIV centres, which was quite a small centre, had a very compromised HIV pharmacy service due to either people self-isolating or being unwell. And at the time, we were considering sharing of pharmacy staff between centres, although ultimately the centre was able to manage their staffing difficulty internally. This was one of the options that we were considering. Back to the overwhelming demand for prescriptions, this wasn't unique to London, and due to a number of people receiving much larger quantities than they normally would, or receiving their prescriptions earlier than they normally would, this led to some concerns about stability of the supply chain, particularly for a handful of antiretrovirals where there was a shortage in supply. So we were able to manage this nationally and limit supply to instalment dispensing, and also ensure that we were able to deliver medication to people so that they weren't having to make extra journeys for this medication as well. And also through collaboration with our professional organisations, national procurement leads and commissioners, as Laura's already mentioned, we were also able to communicate some guidance on initiating antiretrovirals in the absence of resistance testing, being able to take a full drug history, and also support centres who might not have a full pathology or virology service running due to COVID. Another challenge has been supporting our cohorts through a very challenging time, including those who've been stuck overseas, unable to return home, and also those with complex situations, which we've already discussed. So those who might not have access to smartphones, phone credit or data, or might not speak much English, and ensuring that they still have access to the support that they need. During the second wave, we've been able to keep all of our clinics open so far, and we took the opportunity to have as many people attend for bloods as possible between the peaks when it was safer to do so. And Laura's already mentioned the BEVA guidance, which is very helpful on the management of HIV during the second COVID wave. I think the most important point here for pharmacists is the guidance on monitoring and how this shouldn't exceed greater than a 12-month interval, and how we should be flexible in supporting people to be able to attend clinics. The document also states that it's where it isn't possible to undertake the usual monitoring, that ARVs should still be prescribed in all but exceptional cases. A learning point for me as a pharmacist has been that some other pharmacists have felt very conflicted in how to manage this. A number of pharmacies routinely amend prescription length or initiate instalment dispensing whilst waiting for monitoring results. My view is that a prescription length shouldn't be reduced in this way if we don't know the full circumstances of the individual. Although, of course, it's a prudent thing to do in order to prevent wastage if a switch is to be initiated at a later stage, it might be that there's a very good reason for giving a longer supply, and if something's already been agreed, it might result in someone disengaging with care or unnecessary anxiety. And in the case of COVID, although we should of course do everything that we can to ensure routine monitoring takes place, there are actually very few situations where receiving ARVs would do more harm than good. And the only way to identify these is to consider the individual's risks. And the only way we can do this is to consider toxicity, including comorbidities and polypharmacy, and also the risk factors for development of resistance, including the history of adherence and the genetic barrier of the regimen. So senior pharmacists who are well versed at doing this should do everything that they can to support their juniors so that they feel supported to assess this and discuss these cases confidently in order to provide the best possible care. I'm going to stop there because I think I've run over time, but hopefully that was
yeah. Yeah, that was very interesting. Did any of your patients miss treatment due to these logistical challenges that you've highlighted?
Occasionally, yes. We had some courier companies have medication going missing and had to resend. So there were a few people that missed a few days here and there. And we've actually conducted an audit. We've taken a random sample and we haven't analysed that data yet, but it looks like the majority were able to receive their drugs on time.
Thank you. Well done. So our second speaker, please, is Leonie Meemken. She's an HIV specialist pharmacist with 20 years of experience, but specifically focusing now on online consultations and adherence services. And we're very keen to hear from you today, Leonie, about what's currently happening at your services in Vienna.
Hello, thank you very much for the invitation. Yes, I'm a freelancer and I'm creating projects and I'm focusing on an adherence consulting service. I'm in 2 hospitals, in the AKH, the University Hospital in Vienna, and another hospital, Kaiser-Franz-Joseph-Spital. And in the AKH, we focus on chemsex patients because a few years ago we made a questionnaire about drug-drug interactions and OTC and UTC drugs, and had the experience that 43% of our patients are taking recreational drugs. So that's the main problem here in the AKH. And yes, But now is the situation that the AKH, the Kaiser Franz Joseph Hospital, they have closed the outpatient department of HIV patients, and the COVID outpatient department moved in, and so there were only only 2 rooms left for 2,300 patients to see the physicians. And that's right a problem, because the physicians are working, I think, 24/7, until 8 o'clock, and they can only see a patient who are not feeling well or who have got an emergency, something like that. So they started to send the prescription by post. And we also think about what can I do with my service, and I started with this online service, but there's the challenge of the advertisement. We start to make a flyer and put it in the to the prescription, so that the people know. And the patients react very differently. Sometimes they are very happy that they are at home, but a lot of patients also get unemployed, have problems with their job, being at home, feeling lonely, have got fear. Therefore we have to think what we are doing with these people. And we thought there are 2 options. It's one thing, the medical information. We made video clips for our patients, sponsored by Gilead, and there were 13 experts with and talk about different themes, like diagnostic, like treatment, sexual health, medication in treat, and we advertise this videos in newspapers. So we start the service at the World AIDS Day at the 1st of December. Want to share information and encourage patients to contact us online. And on the second hand, we focus on the adherence consulting service, and also we think of a service to make peer-to-peer platform. It sounds a bit crazy, but one patient told me that it's very important to get out of this loneliness and sitting at home. And so think of a peer-to-peer platform. It's a platform from a gaming platform, where you have got rooms, and in these rooms people can drive for cooking recipes, to exchange cooking recipes, or for dancing, or for making yoga together. We have, I don't know if this service will have a good start or not. I can tell you next year, but that's one of our ideas, to get the patient out of this fear, out of the panic, out of getting crazy alone at home. That's also my main interest, to support patients in such a way. And on the other side, also think about our nurses and pharmacists. We are not so well connected like you in the UK, and it would be great if we have got a network together and change also informations, new informations, because we have no workshops in the morning, no workshop at the moment. And yes, that was also a good possibility. I've got one network in Germany. It's called Inixfo, where we have also medical experts in that network. On the other hand, I'm supported by a global chemsex forum with David Stewart, where he supports me in my consulting of my chemsex patients. And that's also going online, and therefore I think it's the main, we are coming together somehow in this pandemic, so we can work together. We have a global aim, so that's the possibility, to get to know each other and share good practice together. That's I hope that we can encourage each other.
Thank you, Leonie, and I wish you luck with developing your network further. It sounds like a very good idea. Can I ask you about consultation frequency? You say it's reduced. How's that impacted on adherence? And is that sort of suggesting that a more community-based approach to HIV care is a step in the right direction?
Yes, we were not sure about the adherence at the moment, because they must be very they have to look after themselves. They only get medicines when they call the clinic and get their prescriptions. So the patients who I am in contact with, it's going very well, but there are some patients who we have no contact anymore, and we can't contact, and we have not access to this patient, and that we have no feeling what is going on in this patient. So, yeah, that's our main problem, to get to this patient when they did not call us. So, what do we do there?
Thank you. Thank you. So I now want to move on, if we can, to Riccardo Rondina, a nurse at the University of Ferrara, Infectious Disease Unit, and a board member of the Italian Association of Nurses in Infectious Diseases. And we'll hear from him today about what's currently happening in Italy. Thank you very much.
Ciao a tutti. Good morning, everybody. Thank you for the invitation. What I could say is that in Italy, HIV prevention services are not like in UK. This to say that in my country, if you want to perform an HIV test, you have to contact or a private laboratory or a public service. I mean, an outpatient or a day hospital. Or the third option is a clinic where there is the treatment of the STIs. In this structure, all these structures are managed by doctors. There is no opportunity, no nurses responsible for a prevention service, and the nurses are not or cannot be autonomous. They must always be accountable to the doctor. In Italy, also, the situation of HIV facility has had a different trend during the COVID epidemic, and depending on the area in which they were located. I mean, in the red area, like Lombardy and Veneto region, these services have been closed, and the nursing staff has been recollocated in other units inside the hospital. In my region, this has not happened. My hospital has functioned or has worked like every day. There was, with no doubt, in the first side, on the first part of the epidemic, I mean from February to June, a strong, remarkable reduction of the access, and I think we had performed only 1 or 2 tests in 3 months. The people that we usually follow, our patient, we have about 90% of virally suppressed people have not big problems, and in our community or in our area, there was something like a slang that said, if you go to the hospital, you risk to get COVID and to die. So probably this was something that has stopped the people for going to the hospital or trying to contact or to be connected with these services. Fortunately, from September, the situation is changing. It's quite normal, or is normalizing, sorry, but with no doubt, there are a lot or many access less if we compare the data with the last year. Most of the patients that we follow routinely were called to assess their condition. I repeat, they have no problem or not big problem, and we told them that we were open in case of emergency. They need no appointment, so they could come freely. We have not used telemedicine, and because it's not possible for us, or the staff decided not to do that. About the distribution of the antiretroviral therapy, our hospital pharmacy has provided regularly the therapy. Usually the patient has 2 months of therapy, but they have exchange for 3 or 4 months maximum. And in 3 or 4 cases, the Red Cross was also contacted to help the people or to give the people the drugs. In this year, we had detected only 6 infections, new HIV patients, compared to the 20 of last year. Where I live and where I work is a very small town. We regularly follow 800 people with HIV. Now the biggest problem is to understand if the lockdown has obliged to the people to stay at home, or if there was an underestimation of the problem. What could happen in the coming month, I don't know. Probably we could assist to an increase of the infected people, and probably they could be hospitalized owing infection, or probably we also will discover a compromised immunological state. For the hospital stay, in the first phase of the epidemic, the direction of my hospital decided to destinate the infectious disease unit for suspected COVID, and we have to reduce the other infectious diseases. And we have an increase of personnel like doctor, nurses, social health care. And after the first phase, there was a transition. Now, since mid-September, we accept only COVID positive, but we have the priority to accept the patient with typical infectious disease. I mean, HIV, TB, scabies, and meningitis. We could reach 24 beds. Last year,
Riccardo, we're going to have to roll it to a close, I'm afraid, because we've got another speaker.
Yeah, here only the last phrase. Last year, we hospitalized 42 patients, 8 died. This year, we are now 23, 4 passed away, but we were accepting 7 new infections. Last year, no one. Thank you so much.
Thank you very much, Riccardo. And so our last speaker today is Catarina Esteves Santos, who works as a specialist nurse with HIV outpatients in Portugal. She's a consultant for the pharmaceutical industry and a lecturer and trainer. And we're keen to hear from her today about the current situation in Portugal and how they've adapted services there in light of the pandemic. Thank you, Catarina.
Thank you. Hello, hola to everyone. I'm talking from Portugal, Cascais, and I'm talking on viewing of this because Cascais since 2017 is a fast-track city to end the HIV pandemic. And we had a really big impact of this COVID pandemic regarding the interventions that we were having until far. Because in 2019, Portugal already achieved the 90-90-90 goals of the UNAIDS. And we were so afraid that we would reverse and step back on these goals. And here in the hospital of Cascais, we have this universal screening program in the emergency department for HIV and hepatitis C from the adults from 18 to 65 years of age. And we compare the same window period of time from March to May of last year to this year of pandemic, and we had a drop of almost 40% in the ER admissions, and in the emergency department screening for HIV, we had a drop for 38% of HIV tests. And in the HIV diagnosis, we had a drop of 83%. So in the same window of time, in last year, we diagnosed 6 patients with HIV in the emergency department, and this year, in the same window of time, we had diagnosed only 1. So in the HIV units that I work, we still maintain the rapid test of HIV, and we also had a drop of 59% of people that were coming to do the tests. So in the issue of diagnosis, we had a lot of drops because a lot of programs of NGOs and also here in Cascais, all the community pharmacies do the HIV test for free. So all these programs were suspended. Only this unit performed the HIV test for the general population that we had. Regarding here in this hospital, we also go to prisons to see the patients. And since March, all the health team were suspended to go there because of the COVID-19, afraid to have it in the prisons outbreak. So as well, in the primary care that we also have HIV tests for diagnosis, none of the HIV tests were performed since March in the primary care. Regarding the linkage and returning in care, here in Portugal, we have the same issues and the same transformation of circuits here in the unit. So we have new circuits for patients to be safe. But we have this problem because we have a lot of patients from Brazil and from other countries that since March, they returned to the country of origin. So we don't know where the patients are. As well as we have a lot of patients working in other countries. So since March, they are retained in that countries. So we had to upgrade the contacts that we have with them by mobile, by mail, and to always keep in contact by a third person that knew about the diagnosis. As well, we have teleconsultations, and as everybody told so far, the mental health is really a big issue that we should have focused before, but this is the plus side of this pandemic. We are now focusing these mental health issues. So I kept face-to-face consultations here in the units. Regarding to access to therapy and to retroviral therapy, we in Portugal, patients pick up medication for 3 months. One thing that the plus side of this pandemic is that right now patients can have the medication delivered at home. This is really good, and also in the community pharmacy if they chose to. Regarding the health literacy, we really bet on digital platforms like Facebook and Instagram, just to spread and to combat a little bit misinformation, because we really want patients to be really informed with valid and real information. That's it.
Thank you very much. Thank you very much, Catarina. So for the last few minutes, we'll bring back in Eileen Nixon, if we can. Many thanks for joining us. And there's a couple of questions that have come into the chat. What level, are you in, Eileen? Yep. A question in the chat box, what level of PPE is ideal for pharmacy and nursing staff in an HIV clinic? In our setting, we can never agree on what's deemed adequate PPE for clinical staff. Eileen, could you respond to that?
Yes, it has changed over the last 6 months. So we very much followed Public Health England guidance. So initially, we had access to full level 3 PPE when we didn't quite know what we were dealing with, and used that quite a lot when we came across people who were symptomatic in the clinic to start with. But for routine care, and because we're screening most people now before they come in, then the nurses and pharmacists, anyone who sees a patient, has contact with a patient, is wearing a surgical fluid-resistant mask, which we're wearing all the time anyway, aprons and gloves, and more recently, people who are not known, that there is no COVID result. So in other words, they may or may not have COVID. We're now advised to be wearing visors, and that's come in really in the last kind of 2 weeks. So we're just starting to get that in place now.
Riccardo, can I ask you a follow-up question about telemedicine? Is this an alternative to face-to-face? And can you get the information you need from patients during these consultations?
I'm not sure, because I asked my doctors if it was possible to introduce this. They are quite not really scared, but probably they will see their role, their status quo, that it should be reduced. So they prefer to have someone in front of, to be more considerate. The other thing, or another thing that I think is that with the telemedicine, or also in this case with an interview or a video conference, is that I could say what I want, even if it's not the truth. So it could be helpful in some cases, but sometimes could be an obstacle. I don't know if I really explain, or if you understand.
Yeah, that's what about e-health tools? I mean, Nadia, maybe you could respond to this. Are we using these well? Is this the long-awaited push in the right direction, or merely a bridging strategy during the pandemic?
No, we don't use that kind of.
Nadia, this is something that you were discussing in your talk.
Yeah, so I think there's a real mix across the board. At our centre, we've used mainly telephone consultations rather than the more complex video consultation apps. So Attend Anywhere is the NHS chosen platform. I think it has a super secure level of encryption compared to other things like Zoom. And there are lots of clever apps that can link in with results, things like Patient Knows Best. And I think the big challenge that we have in the UK with all NHS platforms is that they don't necessarily all talk to each other. Sometimes things can be fragmented, and we're not quite there yet, although COVID has given us that extra push to make things work a bit better. There's still some work to be done, really.
What would you say are sort of the key lessons learned during this pandemic that are useful to take forward?
Personally, the simpler the better, to be honest. From experience of IT letting us down, phone has actually worked pretty well. Obviously, in the longer term, video would be more helpful in terms of being able to read visual cues a little bit better, and also that we can't ever fully replace face-to-face services. But generally speaking, yeah, keep it simple.
Yeah. Thank you. I wanted to also just quickly, for the last minute, follow up on this issue of the role of patients in redesigning your services during the pandemic. Have you all used patients to support the rapid change you had to go through? Maybe Leonie, you could maybe respond to that.
Can you explain what do you mean with?
You've gone through a rapid redesign of how you deliver care, testing, and treatment. Have you involved patients? I mean, there's a big push now, isn't there, to involve patients in the co-design of new services? Have you?
Yes. Yeah, we have done that. We have done it with this, for example, with this Discord, with our peer-to-peer platform. That was an idea of our patients, because our patients, they say they are lonely, they have got fear, then they get into this COVID reality. They are really getting inside this problematic and getting more and more fear. So they come to us and ask us, please help us to get out of this drama somehow. They are getting into this drama, and find some tools where we can make a community, also a big community over the countries, to have cooking recipes with Indian people, or somehow they love this connection with the world, and be at home and finding their own creativity. And that's the thing we get as a feedback from our patients: get out of the fear.
Yeah.
And be
Thank you, Leonie. Thank you. So we've come to the end of this session. It just leaves me now to say thank you very much to all our excellent speakers for their contributions. May I highlight that there's another excellent roundtable discussion in the next session, session 2, which will start at 11:30. We'll now take a short coffee break, and it just leaves me to say thank you very much for joining us today.
Thank you very much for this nice talk.